This con
Okay, so I was going to tell you that we're being recorded. Um, I
I'm sorry,
started
Jeff.
out.
Before you get started, I don't know if Carla and Rebecca know, but they're unmuted. You might want to, just in case there's interference when you start.
I'll go ahead.
And I want to do a shout out. Everybody except for Valerie and Jeffrey is from either Ames, Mars, or as one.
All right. Yeah, great job, Dana. Have you been banging the drums or?
I have, and I know Mars and Ames homes have already implemented most of what's in the new regional center IPP into our ISPs.
Oh, the new one.
Yeah.
Okay. Now, last night at the uh, Kern Regional Center board meeting, Dr. Gates announced that Kern is going to be one of the pilot centers that over the next few months, as they're rolling it out, there's always you find little bugs here and there or things that may need to be modified slightly. And so Kern has volunteered to be one of a few centers that will probably be implementing it sooner rather than later. So where it's going into effect January 1st of 2025, Kern will be implementing it sooner, at least in some areas of IPP development. My career in 1977. And, and back then, we had what was called a problem oriented record. Everything has an abbreviation in the system. So we called it a POR, problem oriented record. And that was where you wrote down on the one column what the client's problem was, and the other column how we were going to try to address that issue. So, client has nothing to do during a day. Client will get a day program. The client has this medical problem. Client will see this doctor. And so it was very much a medical model. I sometimes joke and say one ill plus one pill equals one bill, and that's sort of the medical model. And and then we went in 1978 is when the individual program plan, the IPP, first came on the scene. And for many years, and I think it's gotten better, but there's still a certain element to the IPP process that we see that hasn't really changed over time. And that is where a lot of times it's like events or things that are going to happen rather than trying to address challenges that we may be. So it's still not uncommon to see an IPP that says where the client's living arrangement is going to be. Jonathan will live in the ABC residential facility receiving level 4I services. Then the next one will be Jonathan will be attending the uh, Bakersfield Life day program 5 days a week. Um, and then finally, a third objective, which is Jonathan's healthcare will be maintained. And they're very generic type objectives. They do meet the requirement in the law, which says, especially if a individual, and I'm sorry, I sometimes still use the term client. I'm an old timer. I've been around for many years. That's not really person centered language. We should be talking about individuals, participants, residents, uh, people, basically, because people first. But if I do slip into that, please bear with me. Uh, Anyways, the idea being that you have to have an objective for anything that there's a purchase of service for. So if there is a purchase of service for your adult day services, then there has to be an objective. Now, what individual program plans are going to do is they're going to make it so that we really have to be much more focused. And that's what we're going to talk about today, of how do we go from just saying that the client will attend Bakersfield Life Day program to setting up some very specific person-centered goals and objectives that are what the person needs, wants, hopes to develop, are important for that individual. So with
Jeff,
that, yeah.
sorry to interrupt, but I think Dana has her hand up.
Oh, I'm sorry. Did you have your hand up, Dana?
I did. Did Michi announce her new position last night?
No.
Michi has been appointed by Governor Newsom to a position at DDS.
Yeah.
So it's going to be fun to see how Kern Regional Senator implements this new stuff with some changes happening at the regional center.
Yeah. Well, the director of the regional center works for the board of directors. And so, depending on the direction that the board decides to take in terms of how they want to uh, replace the director, but it was not announced last night. So, but it is sort of public information. It's on the governor's website. Marty Amodia put it out. So I've seen it in a couple different places. So you're right, Dana. So, anyways, over here we have for those of you who are new to this process or who have been with me before, you've probably seen the slide. Basically, you must attend the entire webinar today in order to get CEUs. So if you are looking to get CEUs for the work that you do, please stay on the whole conference. You must identify yourself either through online with your name, or if you're calling in, you need to identify yourself. If there's more than one person at your site on the screen, then you need to identify each person that you want credit for. Within the next month, we request that you send to Irene at Kern Regional Center, and there's her address is listed there, a brief summary of what you learned today. Could be a paragraph or two, bullet points, just something to show that you were paying attention and you got something out of what we did today. And then that will trigger her sending you out your certificate for your CEUs. And we ask that you submit it within 30 days because it just makes it so much easier to just take care of all of the. And then, yeah, Valerie just put Irene's email address on in chat. So if you need to get a hold of her or send her your information, you can do such. Okay. Oops. Oh, come on. Just one. Why is it? It's going. Okay. As Dana alluded to, and as many of you know, there is a new DDS IPP form. It's going to be system-wide in 2022, I believe, 23. The legislature passed a law requiring that there be a standardized IPP statewide. Part of this had to do with the federal government because they under the home and community-based waiver, which we oftentimes refer to as HCBS, those rules for the final rules had some very specific things that needed to be addressed. For day programs, there are 6 areas. For residential, there are an additional 4, so that they have 10 areas that they need to address. Day programs have 6 areas to address. And the state, as part of its plan that it's submitted to the federal government and saying, okay, this is how we're going to address these areas, felt that the one of the ways to do that was to have a uniform IPP that sort of pushes people into, because there are a series of questions that you have to answer in the document. So it sort of creates the parameters for the plan. So it is a person-centered form, as I mentioned. It's going to be set up to try to capture what the person needs and wants, and uh, uh, how the meeting was set up. How is this in line with what the person wants? What some of their hopes and desires are for each of the different services that the person is going to be receiving. How does that relate to their person's short and long-term goals? Kern, as I mentioned earlier, has agreed to pilot it. So Kern will be probably rolling it out within the next couple of months, assuming that any change in leadership won't get in the way of that. And for those of you who are interested, I put the address of where you can find all that information. There's also there's the letter from the Department of Developmental Services, which explains the whole process of what the state's going through right now in terms of the change and the timelines, and a little bit about it. It's got the two forms in this email link, and it also has a training manual that the department put together, a standardized training manual for all of the regional centers to use to train their staff. And it's a good tool. And so if you're going to the annual meetings for individuals that you're serving, uh, getting this tool and reading it and assisting in its implementation, I think would be, yeah, Valerie just put down a better address for that. So if you want to copy that one that you just put in out there, by all means, I would encourage you to do that, because that way you can get the new IPP form. That there's two different ones. They're just very slightly different, depending on which one's used, and and also a training manual and a DDS explanation sheet about the timelines and what went into the process and everything else, and the changes in the law are all in that email. So I would, or I'm in that link. So I would strongly encourage you to download it and get in there, download the documents, and I think they'd be very helpful. One of the challenges, or one of many challenges that I believe we may encounter, um, is that anyone who has been involved in true person-centered type planning, and I know that the Mars Group has done quite a bit of work in this area, and it takes time. It's not something that you do in a 45-minute/hour meeting. And historically, over the last number of years, service coordinators who have very high caseloads, and in some cases are brand new to the caseload, because there's a fair number of turnover of coordinators at Kern Regional Center. And I understand that's more of a systems problem, not just at Kern, although some regional centers more than others. Means that you have somebody who may not know the client that well coming to the meeting. Maybe the first time they've met the client, and they're coming into the meeting having possibly reviewed the chart beforehand, possibly not. Bring in their laptop, have last year's IPP format, and just kind of want to go through last year's uh, decision making and say, okay, so what's changed for this year? And that is not a person-centered plan. that's kind of like, okay, we're reviewing what purchases you got last year, and if there's and has there been any changes? Or do you still live at the same residence that you lived at last year, or have you moved? And also, what's going on with your health? And that's basically a lot of times the only modifications, if there are any modifications at all, under the current system. This new system, if nothing else, in year one, will force people to answer the questions at least one time. I mean, in subsequent years, will we really see IPP planning, or will we see sort of a reversion back towards the let's look at last year's plan and sort of how was that continued? Or each year we're going to be sitting down and doing a unique person-centered plan? And granted, in all of our lives, there are things that don't change from year to year. I go places and they say, "Oh, are you still living at this address?" And I always say, "Yeah, I'm very boring. I've lived here for a number of years. Yeah, haven't moved." Where some people, it's things are very different and very fluid. But in all cases, there are things that are different from year to year. And we really want to be respectful of that. And we want to sit down and we want to look at both what is the short term goal. So maybe from last year to this year, there have been some changes in that. It may not have changed the long term goal that much, but there may be something that the individual wants to do a little differently. So I really do encourage you to go online, get those two new IPP formats, and also the other documents that are on that link. Um, okay, some of the things that I see the most often when I'm out reviewing, and I'm now doing a separate contract from the one that I'm doing with Bakersfield ARC I'm speaking to you today from. I'm also doing a contract with Positive Purposes, and we've contracted with Kern Regional Center to go out and do some of the home and community-based waiver assessments that the federal government is requiring California to do. One of the first one is I see that IPPs are not reviewed, and I put down resident, but it could be participant too. And what I mean by that is it gets written, it gets filed. We come back next year, we write it again, and we file it again. At what point are we sitting down with any regularity and really talking with that individual about, wait a minute, this is your plan, and this was how it was written, and this is what's in your plan, and is this what you really want? Did we get it right? A, and B, is it still like important to you, and is this still what you want? And this should be done regularly. Now, we do for those individuals who are in a residential type setting, anywhere in the spectrum, they're seen every quarter for quarterly meetings. Individuals who are involved in day services and maybe living at home or other types of living arrangements may not, or maybe seen less frequently. But in any case, we are having meetings regularly. And are we really sitting down and pulling out that document and looking at it and reviewing it with the individual? Other thing too is, as you're working with the direct support professionals in your facility, do they have access to that plan? They may not have access to the whole file. It's confidential. We want to maintain that respect for that client's privacy, individual's privacy. I did it again. Don't want to use client. Um, are we? But the plan which that direct support professional is implementing with that individual, do they know what that plan is? So that when they're working with Jonathan, is their activity that they're doing meaningful? Uh, about a week and a half ago, my wife and I were out of town. She had a meeting for her work. And so I went to a local fast food place, got a salad, went to the park, sat down on a bench, and across the way from me on the other bench were three developmentally disabled individuals and their staff person. The three developmentally disabled individuals were sitting there basically staring off into the distance. The staff person had their phone, had the earphones in, and I sat there and ate my lunch for about 20 minutes and didn't see any interaction at all between the staff person and the three individuals. Finally, the individual said, "Okay." He looked at his watch. It's 2 o'clock. It's time to go home. So let me, guys, let's go. And that was the first time I saw this individual interact with the people. How was that meaningful in any way? It probably went down as, oh, it was a community outing today. We went out to this park and interacted at the park. No interaction. No interaction. And very little between the three individuals, and none with the direct support professional who was working with those three persons. So having that be a live document, so it's reviewing it with the individual on a regular basis and documenting that you've done that too, because then you can go back and say, wait a minute, we really believe in choice, and that the individual is a decision maker. So we're going back to them and saying, okay, this is what the team at your behest documented. Is this still the case? And this is what you want. And how do we go and how do we help you in terms of the things that we can do, the supports that we can provide you to make this happen? How do we make it? How do we implement this? The next thing I see oftentimes is that IPPs do not contain information about individuals' needs or goals, and it's limited in terms of person-centered information. When you sit there and say, we're going to maintain Mary's health care, what does that mean? I remember one time reading an annual review that said that this individual continued to be doing well, healthcare continued to be stable, and then later on in the document it talked about that they had like 6 seizures in the last quarter. Well, it didn't sync. So we need to make sure that we're looking at the particular individual's needs. So if we're looking at what are their service and support needs that require them to be in the level of intensity that your facility provides, we want to document that in a positive way, talking about what we're attempting to accomplish, looking at that individual's strengths and capacity and what they like and what they're good at, and how do we incorporate that into their plan to talk about why they're residing in your facility. Same thing for day programs. When it comes to looking at the challenges of healthcare, if the person has certain medical needs, we want to make sure that if there's, we have specific goals and objectives in regards to what sort of healthcare they're going to be receiving, how often, whom, and what sort of treatment plan, and how we as providers are going to support that to make sure that good things happen for this person's health. Choices for community integration and misspelling there, employment are lacking in IPPs or do not exist. So a lot of times it doesn't say anything about, you know, the community or employment in there. And it could be that, you know, if not everybody wants to be in some sort of employment, but maybe they might be interested in some volunteer work, some other community activities, and those need to be addressed. And one of the things that's really starting to get some traction is when we say, oh, we're taking the clients out in the community. What in the heck does that mean? We're taking them out in the community. You know, I I don't use that term when I go out. I'm going on. No, I'm going something specific that's meaningful. I'm going to. Hey, I've got a. Yesterday I had in the afternoon I had to go to the bike store because I had a flat tire on my bicycle. So I had a. So I'm going out to this particular place to take care of this particular activity because it's meaningful to me because I like riding my bicycle. But more importantly, even, is how do we go about developing communities? So I use a few examples that some of you may or may not have heard me share in the past. But what are we doing to get this person involved in a community? So uh, in one case, I had an individual when I was a service coordinator move into a facility. They wanted to go to a specific denominational faith-based program, and so I called the pastor of that particular denomination, made arrangements, got it so that somebody from the congregation would come and pick this person up, take him to the event, go to services, whatever it was related to that faith that the person wanted to be involved with. And then that person started coming regularly. Everybody got to know that individual, knew him by name, would ask him how things were going, what was going on. Uh, if there was like a social hour afterwards where people had coffee and donuts or potluck, this person was involved with that, and they became part of that community. Another story that share is that when I was involved with the Bakersfield Exchange Club for many years, when I was president of the club, I asked my membership if we could have an individual join who had a developmental disability, and everybody said, "Well, of course, anybody can join the club. As long just have to pay the dues, right?" And so we ended up getting an individual. Uh, we talked to Bakersfield ARC. They said, "Yeah, we have somebody that we feel would like to be involved." We went and talked to that person. They were interested. They then started coming to every Tuesday to the lunches. We were actively involved with issues related to child abuse prevention. And this person would come to our fundraisers, to the community activities that we would do, and became an integral part of that service community. So when we talk about going out into the community, we're not just talking about how many outings we do, how many times we take people out there. uh, so, I go out to do some of the HCBS assessments, and what I hear is, "Oh yeah, we go to the park, we go to the movies, we set up a schedule, and we on Thursday evenings we go out to the marketplace and watch the entertainment at the out in front of the fountain." That's not creating community. Um, you and I have people that we have common interests with. We want to sort of create that for the individuals we serve with people who are not other clients or staff. Think about the number of people you work with who, other than their staff or other clients, individuals that they're with during the day and evening, that they're with, who aren't paid to be with them. So almost everybody in their life, if not everyone in their life, is a staff person or another individual who's also a client of the regional center. So how do we go about creating communities? Parks and recreation departments have, a lot of classes. So maybe the person's interested in bead making, and we can find a class that's going on in bead making. Maybe somebody wants to learn about using their cell phone to do photography, and there's a class at the local Parks and Recreation Department. Here locally, both Bakersfield City Parks and Recreation and then also north of the river Parks and Recreation both have a lot of different classes, and they're either free or they're limited charges. North of the river, I think, charges a little bit extra if you're not in their catchment area. But there's a number of different activities out there. There's every month the Bakersfield Life, which is the magazine that's part of the Bakersfield Californian, on the last Saturday of the month, has a schedule of events. So there's you can go online and find a schedule of events. So start looking at those, finding events that people would like to be involved with. The colleges have continuing education classes, education for life classes that you can sign up for, that somebody could maybe take or be involved with. So looking for activities that people can create communities, belonging to gyms and meeting people and doing other things. So IPPs, for the most part, don't really address this issue. And that's one of the things that the new IPP is going to be moving forward with. But again, it's as good as we are in terms of being creative and looking for uh, and developing ideas on how do we create community. Anybody out there, just if you can open up your mic and speak up, have any examples of where they've created a community where someone is involved with non-disabled people? Right. Well, this sort of shows us where we need to, one of the areas we really want to focus, because that's
Sorry,
the.
Dana. Dana, you still have your hand up. Are you commenting? I'm not sure.
Oh,
No, I'm okay. Thank you. No, Jeffrey is saying everything that I have learned with HCBS and the POM method. And yes.
um, all right. The In many cases, the IPP doesn't contain information about options. One of the things that we look at when we go out to do the evaluations, and will become even more so in the future, every year at an individual's yearly meeting, um, we're supposed to be asking that person, is this what you still want? Now, when it comes to, uh, in many cases, the specialized services that some of you offer, there aren't a lot of other options out here. So if you weren't providing that, we're not sure where we could find uh, another organization that could support the level of service needs that this individual is currently in need of. So that could become a challenge. But people are supposed to be offered choices. The same thing happens. I've been out to some of the rural communities in Kern County where there's one provider for the whole area. And so when we go out to individuals and say, okay, you have a choice. Do you want to go to this program or go to another program? And there isn't another program. Is that really a choice? But in theory, and hopefully, especially in greater Bakersfield, we can provide people with some choices. And so that if the person says, no, I really feel that the this particular program is meeting my service and support needs, and I want to continue to receive my supports through this particular provider, then that's what we want to do. We want to, and that should be documented, that we gave the individual choices, and this is the choice that they took. In some cases, especially if it's a brand new individual who's just coming into your program, you would like to, or I would suggest that you talk to that individual and find out where else they looked at, and then really document that as well. so that the individual looked at two other day programs, the Smith day program and the Jones day program, and after reviewing our program, decided that they really wanted to receive services from us. So the document clearly reflects that the person was given options and they chose this particular service. Just like you and I hopefully have options when we're doing things. We can, especially with the internet, you go, hey, whatever, and Siri, Google, whatever, and give me three options for this, and boom, up it will come. So we want to make sure that our individuals have options about what they would like to do as well. Um, Now, one of the things that the new requirements are very clear about, the new HCBS rules, is when you have restrictions, and there are a set of rules that you must follow if you are going to restrict things. So, for example, one of the I'll give you a couple that I've run across where people have had some difficulty with. One is the ability to have a door that locks on their bedroom, and for them to have a key, and for only a limited number of the staff who are specifically assigned with the client's sort of permission, able to unlock the door. So to provide people with privacy in their bedrooms, privacy in bathrooms too, locking doors in bathrooms. Now, sometimes there's a health and safety issue for certain individuals, maybe who are self-abusive or have other challenges that the ID team has reviewed and decided that this can be a health and safety issue for this individual. We need to restrict the ability for them to be able to lock their door per se. Well, there's a whole process that you have to go through. And I won't belabor you all with that right at the moment, but if you need that, let me know through an email. I can send it to you, or you can find it on the DDS online, or Kern Regional Center can provide it for you. But the ID team is supposed to go through a process where you look at what's the less restrictive method that you can use. It needs to be reviewed regularly. It has to be a specific plan. There's some other things involved with that. Another one is the ability to have food at any time. And sometimes that food needs to be restricted because of special diets, or or other challenges that come with that. Visitors at any time, and how does that affect other people living in the facility? So sometimes there needs to be a specific restriction. Now that restriction has to be just for that one individual. So if two individuals in the facility both have issues related to being able to have locks on the doors, there needs to be an individual plan for each one, separate. That is, you can't say, well, this is our our host policy and it applies to these two clients. No, it's got to be. We reviewed George and Sally, and these are based on their reviews. This is what we found. So and sometimes that's done, but then it doesn't end up being in the IPP. So anytime you have any restrictions specifically to the rules under HCBS, those have to be documented, including all the steps that you've gone through consistent with the regulations on that restriction. And then finally, IPP is not in the file. And this is more of a challenge with the regional center than it is with providers. The meeting occurs, and in many cases, you're not getting the plan for 2, 3, 4 months. It just isn't showing up. And unfortunately, it's going back to the regional center after that meeting. Everybody signed that sheet, so at least you want to try to get that sheet that's signed the day at the meeting. Get a copy of that so you have it in your record. I would strongly encourage you after a few weeks to start emailing the coordinator for that particular individual and start asking for, hey, listen, we had The meeting was on July 1. It's now July 31st. What's the progress on receiving that IPP for our records? The analogy I use is if you go to the doctor and the doctor takes a look in your ear and says, "Oh, you have an ear infection. Here's amoxicillin, 50 milligrams, whatever. I don't even know the dosages, but here's the dosages of amoxicillin, and you need to take it 3 times a day for the next 10 days." Then you go to the pharmacy. The pharmacy fills it exactly how the doctor wrote it. And that's really your role in a way, is if that plan is written specific enough, if that IPP is written specifically enough, that gives you the information that you need on how you can specifically provide that person with the supports and the services that they need to meet the goals that were written into that plan. Well, if you don't have a copy of the plan, you're looking at last year's plan, or maybe that one-page sheet that doesn't give you really a lot of information. And so it's somewhat difficult to really fully implement what was agreed to at that meeting. A number of years ago, I went to a hearing up in Sacramento where the legislature was considering some modifications to the IPP process. And a number of advocates and families and individuals got up and said, "Hey, the way they do IPPs, it's not family friendly, it's not client friendly, it's person friendly, it's not. They write up something at the time, they go back, and then we get something 3-4 months later, and sometimes it's not what we thought we agreed to at the meeting. Yeah, and it takes forever to get it. So, and they pointed to, if you look at education, the IEP process, the individual education plan process. There, the plan is developed and it is done on NCR paper, that no carbon needed paper, and copies are torn off and handed out right there at the meeting. So at the end of the meeting, everybody's got a copy of the plan for the following year. And so someone suggested, "Hey, let's look at, why don't we use that model for regional centers? So why isn't the IPP document completed and done right there at the meeting?" Well, and the legislators really liked that. They said, "That's a great idea." And then somebody got up from the Association of Regional Center Agencies, the regional center lobbyists, and said, "Hey, there is no manager at those meetings. There's nobody in charge who can make administrative decisions about purchase of services at that IPP meeting. And if you're willing to give us additional funding to have managers at every meeting, then yeah, we have no opposition to it." Well, they immediately pulled that back again. So as it stands right now, the service coordinators take it back. The manager reviews it to make sure that there's a IPP objective for every purchase of service, that purchase of services are consistent with their regional centers purchase of service guidelines with Title 17 and Lanterman, et cetera. So there's a review process that every IPP goes through, and then it's signed off on by the manager, and then it goes back to the coordinator, and coordinators are oftentimes overwhelmed, and they may or may not then immediately send it out to you, email it out to you. May take a while, may forget. Stay on it. Keep up with folks and say, "Hey, wait a minute. It's been a month now. I haven't gotten it. It's been 2 months now. I haven't gotten it." And then that does another thing. It covers you too. So if an auditor were to come out and sit there and say, "Okay, do you have a current IPP on all the individuals that you're serving?" You could say, "Well, we have 3 out of the 4. The fourth one, we have the document that was signed at the date of the meeting, and here's a couple of emails that I've sent to Regional Center requesting the plan, and I still have not received the final plan that we completed in June of this year on the client's birth month." Okay. Okay. What should be in an ideal IPP? Okay, person-centered approach. And if you go back and look at the federal regulations, we tend to work in Title 17 of the California Code of Regulations. But there is a federal code of regulations too. And if you go back and look at the Federal Code of Regulations section specific to HCBS waiver, you will find that it really looks to person-centered approach as the foundation. So everything that goes into the 10 rules starts off with a person-centered approach. And there's that old analogy: if someone is building a new home and does a lousy job of laying that foundation, so it's not level, there's some problems with it doesn't have good drainage, whatever the issue is, then everything that you build on top of that, everything you build up from that first initial foundation will be off, and you will have problems from then on. And that's sort of how the feds look at this whole home and community-based system, is that first and foremost, we're going into this with the idea of that we're going to do person-centered planning throughout the process. So when we're writing the plans, when we're implementing the plans, when we're looking at all 10 regulations and seeing, wait a minute, this is how we implement this, we're looking at how we implement that specific to that individual. So ensuring that IPPs are tailored to the individual's unique needs, aspirations, preferences, promoting their autonomy and personal growth. And again, this is a positive thing. You know, for many years, we wrote goals related to deficits, issues related to toileting, uh, to decreasing, temper tantrums, to things like that. So they were what the person wasn't doing well and what we wanted to do. Now we want to start from the perspective of, okay, what do we want this person to do? Can't be doing this and can't be doing that. So these two behaviors are incompatible with each other. So instead of focusing on what we don't want, let's focus on what we do want. And what are the person's strengths? What are they good at doing? How do we get from here to there? And so that's what really one of the focuses that we're really looking at. Now, this next one is one of the challenges that we talk about, which is comprehensive information, including a thorough compilation of the individual strengths, abilities, interests, cultural background to inform strategic strategies and interventions. Again, in most cases, you've had this individual, unless they're brand new to your program, and this is the intake or the 30-day planning process. But if they've been there a year, 2 years, maybe a number of years, long-term resident, long-term uh, uh, participant in your programs, this person's pretty well. And so you're going to be able to come into that meeting really knowing what their strengths are, what their abilities are, what their likes are, what their dislikes are, um, and can really present that to the team. As I was mentioning earlier, with the level of turnover and caseloads at the regional centers, and again, this is a system-wide issue, not just our local center. Uh, in many cases, the coordinator is going in and they don't necessarily know that. And did they even spend time before they came to that meeting, if they're new to this case, with that case, seeing what the case record says about this person? And if they are looking at that case record, was it the old way of doing IPPs where the same issue or issues or same strengths got put in year after year after year? And, I could read a document that was 4 years ago, or I could read a document that was last year, and I still wouldn't get a good flavor of what's really going on with that person. So you, in many ways, as the provider of services for that individual, if you again, if it's not necessarily an intake, but you've had them for a while, are the most knowledgeable about some of the service needs for that individual. So this is where you really need to work with that individual. It's their meeting, and they get to make the decisions about what the services are. They get to make the decisions about how they want that meeting to proceed. But with that being said, it's talking to that individual and saying, "Hey, how would you like your meeting to occur, Dana?"
I always tell my care provider, the administrators, that it's really important that the our ISP reflects the client, because we want somebody to be able to pick up that report, maybe somebody like me, to be able to pick up that report and know that client almost as well as they do. I've had several instances where I've been trying to help get something for a client, whether it's medical or one-on-one or whatever, and I have to do a bunch of digging to get that information. If it's in their report, it makes it easier to support them and to support the individual.
Um, yeah, and if it's in the report, you want to make sure that it's current and factual too. That I had a situation where the parent of a client, when I was as in the in an executive role at the regional center, came in and protested. They had gotten a copy of the plan for their adult child, and in there was a notation of a, a sexual incident that had occurred. Well, this had occurred years prior. Two young males in a bathroom. You show me yours, I'll show you mine, or something. And then that went into the record as there being some sort of deviant behavior, and it continued on for many years and created what Michael Small, one of the big gurus in the field of person-centered planning, calls a severe behavioral reputation. It created a behavioral reputation that seemed to follow this individual when it was a one-time event that really had nothing to do with this person's sexuality, their orientation, with anything per se that was relevant to the IPP process, but it continued to be in their yearly annual review, and providers were told that this is an issue that they needed to sort of keep an eye on in their programming and what have you, and really didn't focus on the person's strengths, abilities, interests, etc. It was something that occurred years
I
ago.
I had an incident when I was at the regional center where I was covering a caseload. I read the previous year's ISP or IPPs and all that. I went out expecting to be able to talk to the individual, and I expected that they were walking and talking and all that. They were immobile, they were in a wheelchair. They couldn't talk to me, and I'm like, "Hello, what happened?"
Yeah, clearly the process was not person centered. It was all they had either just copied a document from years ago. Maybe at some point this person was mobile and lost their mobility over time, maybe a neuro disability that was degenerative. Maybe that they just wrote the wrong information. I mean, we don't really know, but it points to not really capturing the essence of that individual. And one of the other things that we want to be very sensitive about these days in terms of the process is cultural issues. California and Kern County both are minority majority areas. So the majority of the population is not Anglo, and so we need to be respectful of different cultures, different backgrounds, and that applies to gender differences too. So if someone has, what is sometimes referred to as alternative lifestyles, or we want to make sure that our planning process reflects who that person is and their strengths and how they want to be treated, how what pronouns they want to be addressed, etc., should all be in their document to accurately reflect who that person sees themselves as and how they want to be addressed and what they want in their plan. Um, 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 Community integration, embedded options within the IPP that offer individuals an opportunity to participate in community life, enhancing their sense of inclusion and belonging. Again, we want to write objectives that are going to really get that individual into the community as a whole and not just, okay, we went out to one program. They said, "Oh, we take our people out 30% of the time. We're a site-based program, but we go out in the community 30% of the time." Okay, so you go out 30% of the time. That's great. I applaud you for that. But what are you doing that's meaningful? And is that 30% of the time going out where a group of clients, individuals go out and to the mall, walk the mall, come back to the program, etc.? Or are they a small group going to the mall, going to the Gap, talking to the manager about what it takes to work there? What are some of the issues? How do you complete a resume? Something that's meaningful to that person's IPP. Because so if that person's IPP talked about, a short range goal, some getting more information about vocational options, to looking towards more of a long-term goal of employment, that would be a meaningful activity, community-based, not just going to the mall. Okay. Um, a ideal IPP, informed decision making, and informed decision making. We all sort of know when we go to the doctor and the doctor says, you have this particular uh, condition or disease, or and there is a remedy for it, and I'd like to give you the shot. And in giving you the shot, I need to make sure that you are aware, or sometimes just hand you a piece of paper that has that and have you sign it. But it says that there is, let's say, a 1 in 50,000 chance that you'll develop hives all over your body as a allergic reaction to this particular injection. I'm advising you as your doctor, let's say as a hypothetical here, to go ahead and get this shot because I think the benefits far outweigh the potential risks. Yeah, yes, indeed, there is a risk that you could have that severe allergic reaction, but it's sort of rare, and the benefits of getting this shot are very important to your um, hang on, are very important to your health. So I'm informing you of the potential risk, and then you make that decision. So we want to do that within this process too. So we want to make sure that if people are making choices, that they've been informed that there are uh, both benefits, and if there are potential risks to that. We also want to make sure that they know that there are other choices that they can make, so that wait a minute, uh, we as a team feel that like this would be a good option for you, but here are some of the other options as well, and ultimately it's your decision which one you want to make. So we want to make sure that we give people informed choices. It's a good idea to also to put that into the document. It should really be in the IPP. We explain the benefits and the risks to George, to attending this particular program versus another program. So if George stated that he did not want to be involved in vocational services and feels that there would be greater benefit from attending an adult day activity program that was involved with meaningful community activity in lieu of employment. Um, Dynamic review process. Conduct regular and systematic reviews of the IPP to adapt and evolving needs and goals in individual settings. The new format, so that if you go online and download that format that we shared the first thing this morning, has on it some drop down boxes up near the top. We click on it, the box drops down. Revision of the IPP is one of them, so that a plan can be reviewed at any time throughout the year. And the way the Lanterman Act reads is that if the individual or their representative requests a revision to their plan, that the regional center has to convene that meeting within 30 days. So that if you find that you have an individual who shares with you that they would like to make significant changes, you can either empower them to get to their service coordinator and request that new meeting, which is really the best way to do it if it's possible, or you can advocate for that person and assist them in the process of getting that together. And then there needs to be a planned meeting within 30 days. Now, the other thing, and it's in that new form as well, if I ask for a change in the regional center, staff person says, well, I can't really make that decision. That's sort of, that may not be entirely consistent with our purchase of service guidelines. So I need to take it back to the center and have my supervisor review it. And I may have to take it to a team meeting and have the team look at. The rule says that the meeting is supposed to reconvene within 15 days, unless all the parties agree to make it longer. And there's now a box on that on the new form where you have to check if not everybody agreed to things at the meeting. So if people say, well, no, we agree to this, but we don't agree to that, then the meeting has to be reconvened within 15 days, like I say, unless the parties agree to do it longer. And then a decision has to be made at that time. So it needs to be a dynamic process. It's not just, okay, we write this document and this document's now good for the individuals that you're working with, who are almost all HCBS waiver eligible, or in any case, they're living in residential type settings. They need to have their plans done annually. The Lanterman Act actually states that it shall be done not more than once, or not more than 3 years. So an IPP shall be not more than 3 years. So for some individuals who are living, let's say, maybe with their families, uh, low intensity service and support needs, maybe the family, or they're receiving a lot of their services generically in the community, they're in public school, there's other resources available to that individual financially, health wise, etc., can be up to 3 years. What the individuals you're serving, they're yearly. But even though, like I say, it's yearly, it's done usually on their birth month. If during that year there's a need to reconvene the meeting, this objective is no longer relevant. And we need to look at another one. The individual has shared with us, because we're sitting down with this individual on a regular basis and talking to him about his or her plan, and they're telling us that, wait a minute, yeah, I thought that's what I wanted when we met 4 months ago, but now that I think about it, or now that we've tried that, it's not really what I want, and I would like to change this and put down something else as what I'd like to do. Then, like I say, you want to encourage that individual to contact their service coordinator and ask to reconvene the meeting, or work with that individual to maybe assist them in the process of contacting the coordinator and getting that meeting redone. So it's a dynamic process, and it needs to be continually reviewed. It's not like we put it in here, we look at it the next quarter, then we do another one, and we do it's ongoing. Collaboratively developed, foster a cooperative environment for IPP creation involving the individual. If they've got family members that are involved, and multidisciplinary professionals, so the service coordinator, if there are other folks, if in your case, for many of you who are involved with specialized services, if there's a behaviorist or some other professionals. So maybe sometimes there's a dietitian, OT, PT, speech. It could be other people that are involved with a particular individual's planning process. We want to make sure that they're giving input into it too. I once ran into this, and I created it into a slide. I'm going to show it again in the near future, I think, where the first slide comes up. It says interdisciplinary planning team meeting. And then the next slide says unnatural event committed by non-consenting adults. And the whole idea behind it is, when we have a team meeting, everybody comes in saying, well, I know what's, I have my perspective and I know what's best. I ain't got my perspective and I know what's best. No, it's a collaborative effort. We want to work together with all the parties to develop something that works. So as the behaviorist shares that, wait a minute, there's, we've noticed that this is really something that's very rewarding and is motivating for this individual. And so we'd like to focus more on, increasing the amount of time that this individual has activities related to this, and so that is a contribution that they make. Maybe if you've got a nurse consultant, that person may come in and say, wait a minute, this is a way that seems to be increasing this person's positive health outcomes, lowering their blood pressure, whatever. And so this would be very helpful to have as part of their plan, because it seems to be making a huge difference. Then that person's giving input. So you want to have a collaborative team meeting so that there's more than just the service coordinator or yourselves saying, I've been to meetings where you go in and the day program has written up a service plan. So here's our service plan for next year. And it's based off of the service plan that we wrote last year. So it's sort of continuation. Or we sat down with John, and we this we're going to keep, this we're not going to keep, this one we're going to keep. And so here's the plan. Well, that's not really a collaborative effort. That's one of the team members coming up with a plan for the whole team. Family members, varies from individual to individual. It's their meeting. Now, I've had some families who were very involved in their sons or daughters or brothers and sisters' uh, life for many years. Now the person's an adult. They feel that they continue to want to be involved, and they look at the person's cognitive, physical, whatever issues uh, are involved in why that individual is in the system, and say, well, because of that, they need me to be integrally involved in terms of making decisions. Well, again, unless that person's gone and gotten a conservatorship, then their ability to be involved is up to the individual themselves. So the individual can decide how they want their meeting, who they want at their meeting. And also, interesting enough, the way the law reads, the individual can decide where the meeting is. So in many cases, you have the service coordinator calling up and saying, okay, we want to come out to your day program uh, next Wednesday from 11 to 12 to write the new plan for George. Okay, well, what input did the individual have? The service coordinator and the day program, or the service coordinator and the residential provider uh, decided on where that plan is going to take place. Individual might say, "Hey, I feel more comfortable at Starbucks. I'd like to have, so, do my plan over a cup of coffee and some snacks." Their meeting, they can make that decision, and that's something that, although it's in the law and in regulation, really I don't see is really being enforced or really been involved. So if the regional center calls and says to you as a provider, "Hey, we're going to have a meeting at this time at this place," hey, ask. So did you ask Margaret if that's what she wants to do? And and is that the place and the time that she would like her meeting to be? Because as part of that collaborative effort, this is their meeting, and we want to be holistic. We want to look at the whole person. So to just pick off one area here or one area here, it doesn't really get the whole person, and then you end up kind of like what Dana was showing a few minutes ago about going out and finding out that the person that you're looking at is very different than what's written in that plan, because people picked off one area here, one area there, and just addressed those and didn't look at the whole individual. And so we want to make sure the plan reflects who that person is. I've been talking, pretty nonstop here. Any questions or concerns, or did I set up a red flag that somebody says, "No, no, no, that's not right. You need to take a step back. You're being a little bit too radical in terms of your thinking." This is
I'm
your
good.
chance.
I think
Okay.
you're this is Dana. You're covering what what has been expressed with HCBS over the past year. You're doing a great job, Jeff.
Well, thank you. For those of you who may not be aware, I worked at Regional Center for about 34 years, left, and then at some point, sort of did a few different jobs, worked at mental health, did some work down in Southern California, and then I was asked to come back by the director of Bakersfield ARC to really look at developing their plan for HCBS. And then there's also another program, which really we haven't seen that much of for our individuals, but it's called WIOA, the Work Opportunity and Incentive Act. And it was also passed around the same time as HCBS. And that is specifically related to employment. And it is a comprehensive employment federal legislation, and it deals with all types of employment. So all unemployment benefits, American Job Centers, a number of Department of Rehab functions, a number of things all fall under WIOA. And so as we move more and more into employment for the people that we serve, we may see more of it. But it really hadn't, at the time I was first hired, I was told, hey, you're going to work on both of these. Very shortly after that, sort of the WIOA stuff sort of took like a backseat, and the primary focus was on developing HCBS plans. And so that's sort of morphed into what I'm doing now in terms of the consulting work that I do. Okay, so again, and this is, we're some of the stuff is redundant and sort of meant to be that way, because if you go back and you look at the 10 rules, some of that's redundant too. It sort of goes over the similar areas a couple of times. Individual plans should be centered on the person, reflecting their unique needs, goals, and preference to support their well-being and growth. I used to make the joke about the tail wagging the dog. And that was where you have an individual go to the intake at a day activity center, and the day activity center says, okay, from 8 to 9 we do this, 10 to 11 we do this. So this is our structured day, and so this is what you'll be involved with when you come here. And that's not asking the individual, what will you want? And so I went out to one program that was teaching independent living skills, and that somebody asked me, well, we have this one individual, and when we do the specific class on cleanup of the kitchen, and keeping things clean and sanitary and food safe and what have you, he doesn't he's not focusing. Some days he doesn't even show up for that particular class. He's kind of a class clown. He's doing all these things that are where he's not benefiting from this class. So what can you do to help us to get this individual so that he's more in tune with our class? And I asked the question, did anybody ever ask this individual, does he want to go to this class? Does he think this is something that's important to and for him? I mean, we all think it is, because if he's going to live independently, food safety is something that's important. But has anybody asked him? Has anybody talked to him? Has anybody shared with him the benefits and risk of the whole area of food safety? No, we just 2 o'clock. That's the class. We have the schedule, and so he's part of that group that goes into that class at 2. And so I said, well, let's take a step back and look at focusing his plan on what his unique needs are and goals and preferences. And it is critical for the IPP to include detailed person-centered information which encompasses individual strengths, capacities, preferences, lifestyle, and cultural background. So we want to know that as well. If you go to the Kern Regional Center website and you go into the transparency section, one of the things that's in there, which is I find it interesting, but then I'm sort of a statistical wonk, so what I find interesting, most people don't, and that is that they every year they come up with information about purchase of service by diagnosis, by ethnicity, by age, by a number of different factors. And when you look at purchase of service by ethnicity, and then you drill down even a little further and look at it by adults, so basically 21 to 60, not including elderly, you see some huge differences in the purchase of services. There's for Anglos, versus Hispanics, there's almost a $20,000 a year per capita difference in how much is being spent. And at first I looked at it and I said, wait a minute, I've never known the system to be prejudicial. So I've never known that somebody looks at a last name and sees a Hispanic surname and says, "Oh no, we're not going to give them as much services. We're not going to give this family the same." Uh, but if you drill down further and start looking at what some of those purchases of services are, what you find is that if you're Anglo, you're almost twice as likely as an adult to be in some sort of out of home living arrangement versus living with your family. And what's the most expensive service that's out there? Out of home living. So you sort of pull that out of the equation, and then those numbers get a lot closer. But the reason I'm bringing this up is that's a cultural variable. So, if one culture views, being part of your family versus being independent somewhat differently, then that's something we should be taking into consideration when we're working with that person and looking at their plan and looking at. So if somebody, for example, came into your system because they were court ordered, and maybe the family would have really liked them to continue to be with them or whatever, that's a cultural issue. I mean, there's a couple of different cultures clashing, and how do we go ahead and manage that, and how do we work with that and be respectful of all the parties that are in that meeting. So we really do want to ask people about if there are cultural issues, there are things that they would like to see, because we don't always realize it, but there are different ways of viewing things around us. I worked with some individuals from the Iranian community down in Los Angeles after I left the regional center, and there was a group that viewed disability sometimes as shame based. That if you had a family member who was disabled, it was something. It was sort of a karma sort of thing. It's something you as a family did at some point, and maybe in the past, that this is sort of a retribution, and it was shame that you had this member of the family that had this disability. So different culture, how to approach those families differently. When you're, I've seen situations where some families didn't like me coming out to their home because then it just sort of pointed out to their neighbors that they had somebody in their family that had a disability and what all that meant. So when we're talking with people and looking at developing services for folks and supporting that individual, we want to be respectful of who they are and where they came from and how that affects their service and support needs. Okay, it's now basically 11:24, and I want to leave time open for any questions or concerns that anyone would like to address. Or also, interested, are there specific topics that people would like to see in the future? This is an ongoing process. We're going to continue this. We've got a grant for another year, so I will probably be offering these webinars monthly for at least another 13, 14 months. And I'm open to any suggestions or comments that people have today.
I would like to see an open forum where we talk about different community activities or community events that we can involve people in. Maybe we need to have a group of people that keep everybody informed of things that they've heard about.
Uh-huh.
Just because we're not, I mean, we are all in different parts of Bakersfield, and maybe somebody has heard of a something going on at this park or at that park, or movie activities. I don't know, but if we could do something to help us engage our individuals, and that, because that's the biggest issue I see.
Yeah. Great idea, Dana. The only thing I would caution about is we don't want to create activities that a lot of facilities then flock to, because then would be creating another basically activity for persons of IDD. We want to look to find activities that the general public can go to. Hey, let's say for example, I found that through the Levin Center at Bakersfield College, there are a whole series of courses that anybody in the community can take,
Yes.
and maybe a couple of your client or two who might be interested in a this class could go to, and maybe somebody might want to go to that class. So but I think that's a great idea, and I think we can. It probably would be. I would look at it. We also do community of practice, and I think that's probably a better place for community of practice. And so I will look at trying to integrate that into the next session or two that we do, which is on community of practice. There's one for residential and there's one for day services right now every month. After October, we're going to probably just go to one community practice a month, but that would be a really good place to put that. So thank you for that
Well,
suggestion.
I'm not looking at making more just activities for our individuals, but yeah, like the Levin, or maybe somebody has heard of something else that's just a sounding board.
Exactly. I think that's a great idea. Yeah, the only like I'm saying that that's the only one caution. I think sometimes people tend to look for something and then gravitate towards that, and then and don't. We want to be as creative as possible in our thinking. Other suggestions or concerns? Okay, so again, if you are interested in the CEUs today, please send Irene the three things that you've learned today. And I hope everybody has a good week. And tomorrow starts August, right? We're moving right along. Okay, you take care now, and good talking to you today. Bye bye.
Thank everybody for showing up today. Thank you, Jeff, for all your invaluable information. And we'll see you guys soon.
Thank you, Jeff.
Thank you.